He has given me a task of presenting the extreme cases of retinal complications of cataract surgery. So I was, I would say, lucky enough to face a similar situation just a couple of years ago. A patient was referred to me, a patient of Marfan syndrome. He was taken up for surgery for cataract. The nucleus got dislocated, and a week later he also developed a detachment. So here is the story of this encounter called Double Trouble.
Double fire, burning cold and bubble, double, double, toil and trouble. Something wicked this way comes. I felt and tore from, worn about and tongue of dog. Heard the smoke and blind would steam. This is leg and now let's wait. Double, double, toil and trouble, fire, burn and cold and bubble. Double, double, toil and trouble, something wicked this way comes. In the cauldron boil and bake, feel it over fenny snake, scale of dragon, tooth of wolf, witch's mummy, mourn and gone.
Three months after the surgery, silicone oil removal with retrofixated iris claw lens implant was planned.
The second situation is a one-eyed patient, hypertensive and on blood thinners. He came with a history of cataract surgery, which was uneventful but to start with, but later on surgery was abandoned because he developed suprachoroidal hemorrhage. So I'll just briefly show you how we managed this situation. complete resolution of the choroidals. Third interesting situation is a very florid endophthalmitis presented to us with a surgery done 1 week ago, small incision cataract surgery, which was uneventful. And you can see an abscess there at the scleral tunnel itself and a huge hypopyon, and the cornea has become very cloudy. So we planned a triple procedure here. We did a patch graft to the corneal area of melt. Also did a pars plana vitrectomy, and vancomycin fortum was injected intravitreally. This patient started with PL plus in the beginning, ended up with 2 meters vision with this triple procedure, and we identified this organism as one of the rare Morganella morganae organism in the vitreous cavity. Thankfully, the patient did well at the end of 6 months. He still has a corneal opacity there, but has a fairly useful vision. Thank you.
Thank you, Dr. Aditya, for such wonderful cases.
Thanks.
Again, we start with the first one, the nucleus drop and RD. Anyone has any comments to make?
Yeah, Dr. Aditya, nice videos. As you pointed out, like when you are doing fragmentome with your phaco needle itself, you're keeping your half sleeve over there. Otherwise, the fluid keeps leaking and your bottle gets emptied in within minutes.
Right.
And you don't come to know. And that time your staff has to be very cautious, like the pressure, the intraocular pressure is well maintained.
Yeah.
So, usually I also do the same thing, but I don't use half sleeves because then you have to enlarge the sclerotomy site also.
That's right.
So through the same 23 gauge or 20 gauge sclerotomy, you can.
Thankfully, in this patient, he's high myope Marfan's case, so PVD was already there. But I'm sure it will be very challenging in a patient where the lens is already dislocated and the PVD hasn't occurred. So how would you encounter a situation like this, Dr. Sangeet sir? I mean, your inputs.
I think one important thing is if you're using a fragmentome, even in a retinal detachment cases, you have to remove the vitreous completely before even attempting to remove the lens matter which is there, because you may, if you are applying a suction which is too high, you may catch hold of the retina very fast. So one thing I would like to ask you is, when you are doing your case, you put in some PFCL to stabilize the retina and then you took out the lens. So why not put more PFCL, bring it more anterior and then remove it?
Could be done.
Yeah.
That could also be done.
Yeah. So the second case about suprachoroidal hemorrhage, I think the most important thing in managing suprachoroidal hemorrhage is the timing of the surgery. So that generally Dr. Lakhanpal's study has shown about 2 to 3 weeks it takes for the clots to liquefy and then you do it. So do you think, is there any role of TPA injected into the suprachoroidal space and then removing? If you need to do an urgent surgery in these cases, like in your case, there was a RD in there.
Yeah, maybe it's a good idea, but to be very frank, these incidences of suprachoroidal hemorrhages have become really rare thanks to the advent of phacoemulsification. So I'm sure many of us don't have that experience of managing a suprachoroidal hemorrhage nowadays.
Yeah.
Maybe Dr. Bhinde sir has something to add about TPA in such cases.
TPA, again, because these are the eyes, you have a massive hemorrhages, and TPA will act as a localized area. So unless you inject at multiple places, and you are injecting here blindly, if you are subretinal, we know exactly where injecting, so that's a different ballgame. But suprachoroidal space, I think that localized area will liquefy. And also to act it, you need to wait for 45 minutes. So almost minimum 45 minutes. So you'll have localized clot come out, again you go somewhere else, again you go somewhere else. Practically, it's
I think one day before, if you inject TPA in the suprachoroidal space, I think that will be...
No, because these are massive hemorrhages. And you have so much of clot. So, see, unless you have that pocket will remain there, it will liquefy that area. Okay, and then you move other way. And still, most of these eyes, because even after 2 weeks, you will realize, and all of us have experienced, you cannot drain everything out. He is lucky, I think, most of he waited for longer time, so most of the thing came out. But end of the surgery, you will realize bumpy areas here, there, because everything doesn't emulsify or liquefy at the same time. So there are difficulties. RD, if IOP is not under control, you do not have, with the maximum possible medication, you sometimes do not have a choice. So maybe after a week or 8 or 10 days, whatever you see isolated pocket on ultrasound, you go drain, again wait for take another time, something like that. These are difficult cases for anybody to handle, but that's a difficulty. You can inject, but one thing you do not know how much deep you should go, because you can't see. and it acts only localized area. So subretinal, what we know is we inject in a vitreous cavity previous day. Wet-atten, we know that it's percolate through the retina. So that's a different ball game. Here you are doing like it's between the choroid and the sclera. So that's the practical difficulties there.
The last case, endophthalmitis again. In endophthalmitis, what is your usual way of doing it? Like you do a core vitrectomy and then leave it, or you do a complete and then put in oil or something?
So going by the clinical picture and also the presenting visual acuity, if the visual acuity is better and probably clinically it looks like gram-positive organisms where it's a low-grade endophthalmitis, I usually do only tap and intravitreal injections. Otherwise, I do a vitrectomy as much as possible, but don't try to induce the posterior vitreous detachment if it's not coming very easily. But I don't use silicone oil or I don't do vitreous-based shaving in such cases. And at the end of it, obviously, I give intravitreal antibiotics and steroid.
So I think we need to realize that when we are dealing with an acute endo, I think probably the retina is so inflamed that at that time, until or unless you have a complete PVD, it's a good idea to do as much of vitrectomy. But I think otherwise, we need to really hold our hands back and just do a limited core vitrectomy, make a space for the antibiotics to act, and probably follow up these patients till the time the PVD gets induced, and then go back again and do a more complete vitrectomy. I think that works the best, because rather than creating a mess in the first time by being more aggressive and trying to put in silicone oil, I think the ultimate recovery of the patient or the prognosis really gets impacted.
Absolutely, because the goal here, as you said rightly, is to reduce the microbial load rather than anything else. So.
I think I would like to add, if you're dealing with traumatic endophthalmitis, there is, I think we try to induce PVD and try to take as much possible vitreous out.
Thank you. Thank you.
So thank you, Dr. Aditya, for such a wonderful cases. And now I invite Dr. Neeraj Sanduja to present his cases.
Thank you, Dr. Sangeet, for including me in this presentation. So I'll be showing 3 different cases. This was a 35-year-old gentleman who came from Uzbekistan. He had undergone right eye vitrectomy with silicone oil injection for myopic retinal detachment and underwent silicone oil removal, and he had a macular hole now. In the left eye, silicone oil was still there for myopic retinal detachment. It was 5,000 centi-stroke oil, which we realized when we planned vitrectomy for this patient for macular hole. He had cataract, 5,000 centi-stroke.